So very good evening to all of you present here, Dr. Shalin sir, Dr. Shantanu, Dr. Ashutosh, and all the participants. This is our 16th online teaching class under the banner of UP chapter of Up-Aroi. And for head neck session, this is the 10th class. So we are just going to start. Before this, I just want to ask from our residents who are present here and who will join soon, that about your feedback regarding the class schedule, as most of the participant has asked for the evening classes. So I just want your feedback whether it is comfortable to you for morning classes or evening classes, because we will start our evening session in our breast session soon. Yeah. So I just want feedback from our students who are participant here for the schedules. They are more comfortable evening or they are comfortable morning, so that we can plan our further schedule. So for this class, I would like to invite our moderator, Dr. Ashutosh Mukherjee. He is the professor and head, Department of Radiation Oncology, HBCHN MP MMCC Varanasi. Dr. Ashutosh, it is over to you.
Thank you, Dr. Surbi. So I would welcome all our residents to this 10th class in head and neck and 16th class overall. We are having a slightly different topic today. It's on the role of dose escalation and altered fractionation in head and neck cancers. Now, these are two important topics because lot of our practice is based on these topics. And for this, I would invite Dr. Shantanu Sapru, who is an associate professor at RML Ram Manohar Lohia Institute of Medical Sciences, Lucknow. Dr. Shantanu has been a close associate of mine, and he has a very high regard in, people have a high regard for him in the field of academics and in research. And it is our pleasure that he is presenting this difficult topic to us today. So I invite Dr. Shantanu.
Thank you so much, Dr. Ashutosh, and thank you, Dr. Surbi. Good evening, everybody. Today's topic is basically on altered fractionation RT in head and neck cancers. So a couple of ground rules for this. First, this topic cannot be covered in 1 hour. I mean, if I were to take this topic, I'll probably take around 2 weeks to cover it, maybe more. So I'll try to distill the essence of what altered fractionation RT is all about and try to present a broad overview of what altered fractionation RT is and where it is used and where it should not be used, maybe. Second, when we talk of head neck cancers, I am basically referring to head neck squamous cell carcinomas. So nasopharyngeal carcinomas will not be covered, as will not be covered tumors like sinus tumors and esthesioneuroplasmomas and other salivary gland tumors, because those are not typically considered as head neck HNSCCs. And third, I wish somebody had taken this kind of lecture for me when I was an MD, because I understand that a lot of you are an MD students, and my presentation would be not to bore you or overwhelm you with too much facts, because you can read them for yourselves, but to give you a conceptual overview of the whole thing. So with these caveats, let us start thinking about what any treatment of any medical disease is about. It's basically about you give a treatment and you want some cure, but you don't want too many complications. So any treatment of any kind of any disorder is about balancing cure versus toxicity. Similarly, in radiation, because we give radiotherapy and radiation doses, we are always talking about the dose of radiation, what tumor control probability or TCP, which is our surrogate for cure, what is the TCP it causes, and what is the normal tissue complication probability or NTCP, which is the surrogate for toxicity or complication. What kind of NTCP that dose causes. And our goal is basically to try and balance them. And one of the things which we can do is we can try and found out for what doses, what percentage of probability of TCP or cure is possible, available to us. And for the same dose, what percentage of probability of complications or NTCP is available. And obviously, if the cure is a higher percentage of probability than the complications, then obviously it's a good thing. So if we plot dose on the x-axis and if we plot percentage of probability on the y-axis, and we can do this both for the TCP and NTCP, this curve shows for TCP, but you can do it for both. You will see that we will have a sigmoid curve, which means as the dose increases, first there'll be a slight rise in the probability of whatever, of both tumor control and of complications. Then there'll be a steep rise, and then they'll sort of plateau off. So it's called a sigmoid or an S-shaped curve. And one of the immediate things you can make out from this, that there will be a dose relationship between the NTCP and TCP curves. So for a given dose, let's say A, there will be a certain probability of tumor control from this curve, and there'll be a certain probability of NTCP. So if I were to say B, around tumor control will be somewhere around 50%, while normal tissue will be somewhere probably around 8-10% or something, maybe 9% or so. So this is a good thing. This is what we want, sort of. A related term to this is what is called therapeutic ratio, which can conceptually be understood as the difference between our TCP and NTCP curves. If the TCP and NTCP curves are farther apart, like in figure A, this is a good thing. If they are closer, then it's probably not that a good thing, because that means for each gray of dose, for whatever tumor control you have, you will be having pretty much similar normal tissue complications also. So the therapeutic ratio will be considered as low here. Now, therapeutic ratio in different books is defined as differently. Some people refer to a therapeutic ratio as for a given percentage of effect, the dose causing TCP divided by dose causing NTCP. So it's in terms of doses for a given effect. Other people define it the exact opposite. For a given dose, what is the effect? For example, for dose D, what is the percentage of probability of TCP divided by the percentage probability of NTCP? So you can define it either way. That's all right. These are the two standardized definitions in the literature. But our basic funda is to understand that the NTCP curve, which is the dashed curve, it lies on the right side of the TCP curve. If it actually lies on the left side of the TCP curve, then it's nearly impossible to give enough dose to have reasonably uncomplicated control rates or cure rates. So the whole assumption or the whole understanding behind anything in radiotherapy basically is that the NTCP curve is on the right side, and we are always trying to further push these curves apart. So our basic goal is to try and push this red curve to the right, or the left curve to the left, because blue curve to the left. So the blue curve, the TCP curve, can be pushed to the left by multiple things. For example, by adding chemotherapy, or as is apt in our today's lecture, by changing fractionations, or by increasing total dose. So this is how you can increase the tumor control rate. However, many times the TCP rates curve either stays the same or it also moves to the left, but ideally it should move to the right. Now, this moving the NTCP curve to the right, the adverse event curve to the right, this is usually the purview of advanced technology. When we talk of IGRT and all these kind of technologies, adaptive radiotherapy, this is what we're planning to do. We are planning to use physical things like PTV margins and motion management, so that we can move the NTCP curve to the right, and hence for a given dose and whatever the tumor control we have, we can probably have lesser normal tissue complication probability. This is what we are trying to do most of the times. Now, this will be sort of relevant to you later on. Now, how do we go about this? So there are two concepts which you should understand. One is called BED, or biologically effective dose. This is the formula. I'm sure you know it. If not, you can read up from standardized textbooks. For most EBRT purposes, this right side of the BED formula, the gamma by alpha into T minus TK, this is usually neglected, because this basically has to do with cell doubling time or cell proliferation time and the overall treatment time. Gamma is something to do with overall treatment time, and TK is the time in which there is no assumed proliferation. But as we will note, altered fractionation may have an impact here. This was more relevant in the era of LDR brachytherapy, but this has been taken into EBRT also. Although for standard fractionation, we neglect this particular half of the equation. And this is what you know of, D into 1 plus D by alpha by beta. This is the standard BD. But this part is important also. So how do we make out a new dose fractionation schedule. We all know standard fractionation, 70 grain, 35 fractions, 60 grain, 33 fractions, 60 grain, 30 fractions. But how will we find out what is a new fractionation? And with this, for this, we have something called the Withers ISO effect formula. This is the formula you can read up from, again, standardized textbooks or articles. Basically, you have a new versus a reference, and you need to know what you have the total dose reference, what was the dose per fraction of the reference fractionation schedule, and then you should either know what fraction size you're going to have, or you should have some total dose in mind. So you can only keep one variable as an unknown variable. And alpha beta, of course, is alpha beta for different things. Now, one thing which you should keep in mind is that when we are making new dose fractionation schedules, we not only try to keep the BED equivalent to standard fractionation, but we also try to give BED equivalent to standard fractionation in terms of both alpha beta for normal tissues and tumor control. So most of the times you will find that there will be BED grade 10, which is generally assumed to be the alpha beta ratio for head and neck squamous cell carcinomas, and also for acute responding tissues. So BED grade 10 is the alpha beta chosen for TCP as well as acute NTCP. On the other hand, BED grade 3 is usually chosen, alpha beta of grade 3 is usually chosen when we talk of BED grade 3, which will be late toxicity in terms of NTCP. So we try to balance these as much as possible. So with this conceptual framework in mind, let us start about what exactly altered fractionation is. Now, obviously the first thing is, what exactly do we mean by altered fractionation? So before that, we have to first define standard fractionation. Now, we all know, as I said, standard fractionation is 70 grain, 35 fraction. What most people forget, and which is more important, is this part in red, the second part. The dose per fraction, the delivery, is it 1 fraction per day or more, and how many fractions a week? This is what makes it not standard or normal fractionation. We often forget this because we usually use standard fractionation in clinical practice, so we omit this. But if you're doing clinical research or if you're reporting something, you will have to write these things down, because otherwise people will not know whether you are actually saying standard fractionation or you are accelerating in some way or the other. So with this in mind, altered fractionation basically means anything can change. Any of these parameters can change. And based on that, we have basically 3 types of altered fractionation. One is called hyperfractionation. The rationale for hyperfractionation is to separate the TCP and NTCP curves. Now, this is a rationale I have given the therapeutic ratio for everything. But where hyperfractionation acts is actually trying to shift the NTCP curve to the right. And how does it do that? It does that by decreasing the individual fraction size. That means if you see here, the fraction size is less than 1.8 to 2 gray. It's somewhere between 1.2, 1.3, 1.1 gray, something of that sort order. But then if you did that and gave only OD, you will never be able to have good control rates, tumor control. So you deliver this fractionation more than once in a day, BD or TID. TID is usually a rare, but it has been done. Usually at least a 6-hour separation should be there between the 2 fractions. Now, because we are actually fractionating our standard fractionation, each fraction is being sort of fractionated, we know that the cell survival curve with this will shallow out even more. Because of this, we need to increase our total dose. So you will almost always find that the total dose of the hyperfractionation schedule will always be more than a standard fractionation. It took me some time in my MD to figure this out, that it was not due to accident. It was designed to do this. So, and most hyperfractionation, pure hyperfractionation, plays around with dose per fractionation, the timing, and the total dose. It keeps 5 fractions per week. The rationale being that even though my TCP either remains same or will increase a bit because we are increasing total dose, so acute NTCP will increase, but late NTCP will probably go down. And this has been borne out in the trials also. So the rationale being TCP either increases or stays the same. NTCP, especially late toxicity, goes down because the NTCP curve shifts more to the right. Acute toxicity is usually higher because the total dose is usually higher. And because of that, the alpha beta of grade 10 is what is used. The second kind of altered fractionation is what is called accelerated fractionation. Now, here it is possible that if you remember that gamma by alpha and T minus TK term, this is where it might come into the picture. Because what is the rationale of accelerated fractionation? The rationale of accelerated fractionation is actually to try and decrease accelerated repopulation, one of the R's of radiology. That R, we have to try and decrease that. We often know that this accelerated repopulation occurs somewhere around 2 to 4 weeks. And this is where the purported effect or the benefit of accelerated fractionation RT is supposed to take place at. Now, because of this, what we will be doing, you'll be seeing most of the times acute and late toxicities usually are higher than standard fractionation. Now, there are three parts or three types of accelerated fractionation. One is called pure accelerated fractionation, in which case you keep the dose per fraction the same as standard fractionation, but you increase the number of fractions in a week. So you can have 6 fractions a week or even 7 fractions a week, which is rare. But 6 fractions a week has been tried and has been tolerated reasonably well. Now, the dose is usually similar to standard fractionation or less than. In a couple of trials, they have done more than that, more than standard fractionation than total dose, but they had a lot of toxicity. The second type is what is called as concomitant boost accelerated fractionation. This can also be considered a hybrid type because it has 2 different dose levels. So you have dose level X1 or D1 and X1, X2 or D2, which are distinctly separated in time. So it can be either given, concomitant boost can be either given in the same day. That means your first fraction, standard fractionation given at, let's say, 10 a.m. in the morning, and then after 6 hours, you give another 1.2 or 1.5 gray concomitant boost. Or you can deliver this boost to a different volume on your 6th day. So 5 days standard fractionation and 1.5 gray on your 6th day, 6th fraction. So it can be either BID or 6 fractions a week, which is why it's considered not as a pure acceleration, but as a hybrid acceleration, form of hybrid acceleration. Now, again, the total dose of this form of AFRT is usually equal to or lesser than standard fractionation. So if you have 70 gray and 35 fraction and you're doing some kind of acceleration, you would not cross 70 gray. You'll probably go 66 or 67 or 68 gray or something of sort of, maybe 70. People have done 72 and 74 and they landed in trouble. And the third is what is now latest followed, what is called as SIB. Now, if you notice, this was a distinctly separated in time. That's what I've highlighted in bold here, because there are 2 different dose levels which have to be separated. Here, there are 2 different dose levels, or you can have 3 also, by the way, which are given simultaneously. Now, this is basically possible only because of intensity modulation of some kind. It can be intensity modulation normal, it can be VMAT, it can be other kinds of intensity, proton, photon, whichever it is. But once you have the technology to modulate intensity, you can do this kind of SIB technique, which is called simultaneously integrated boost. Again, similar concepts as concomitant boost apply. The total dose is either similar to or lower than, usually lower than, sometimes higher than, but not by much. And then there is something called as mixed or hybrid AHFRT or HAFRT, which is basically any combination thereof. Some people include accelerated fractionation also as a form of hybrid because it combines some element of hyperfractionation because the dose per fraction is lower. Although I would like to point out that pure hyperfractionation has only 1 dose per fraction. That means 1.2 gray per fraction divided by BID or TID, for example. This will have 1 standard dose per fraction and another which will be lower than that. So there are 2 distinct dose levels. So what exactly is meant by hypofractionation then? Unfortunately, the literature, there is no standardized or universal definition of what hypofractionation means. We all know that it means that the dose per fraction will be more than the standard. That means more than 2 gray per fraction. However, what about 2.2 gray per fraction? Is that hypofractionated? A lot of people will say yes. A lot of people will say no, that's acceleration. That's not hypofractionation. People usually start talking hyperfractionated when the dose per fraction starts exceeding 3 or 4 or 5 gray per fraction. The distinct thing though is that it is still delivered once a day and it is still 5 fractions a week. And usually the total dose for hypofractionation is almost always lower than whatever it was for the equivalent standard fractionation plan. So you can make out that this terminology basically came from palliative RT. It's basically a subtype of accelerated RT. It's like an extreme acceleration, but it started off with palliative settings like 20-5 for bone mets or 8 gray single fraction of bone mets or 20-5 for brain mets or 13-10 for, let's say, your head neck carcinomas, whatever. But now, in the past 15 years or so, it has started gaining traction because of technological improvement and more accurate understanding of radiobiology. It is now coming up in breast and prostate and pancreas. So we have a lot of hypofractionated trial in prostate, for example, CHIP trial, for example, and we have for breast also. However, a lot of people would say that if you are giving 2.2 gray per fraction or 2.4 gray per fraction, that's not really hypofractionation, it's acceleration. But hypofractionation is a form of acceleration, especially when the dose levels are different. If they are very different, then you consider them hyperfractionated. So if you have 5 fractions, 7 fractions, 10 fractions, and the total dose levels are very different, if you were giving 70 gray somewhere and now you're giving 30 gray, that makes a difference. Today's topic is head neck cancers. In head neck cancers, hypofractionation, as it is generally understood, is basically used in palliative settings. It has not really entered into the zeitgeist to be used in those settings as it has for example, pancreas and for prostate, for example. So if I say use the word hypofractionation in my terminology here, I would mean in the settings of palliation, mostly in head neck cancers. This is what the topic is. So we have now discussed what the theoretical underpinnings are for altered fractionation. What are the types of altered fractionation? What do we mean by that? And I hope that these lectures will be distributed to you so that you don't have to mug them up. Now we will come to the overview of what the literature says. Is there any evidence behind all this? And the problem is there is too much evidence. So I'll quickly go through some tables. Okay, there'll be like 8 or 9 or 10 tables. I'll quickly go through them. You don't have to mug anything up. Each of these articles or trials can be a journal club of 1 hour unto itself. So obviously I will not cover them in depth, but you can understand and get an overview of how complex the scenario is. So these are some of the studies which have compared normal fractionation with pure acceleration. And one of the largest trials in this, of course, is the Dahanka 6 and 7 trial with around 1,500 patients. These are more studies, the Overgard, the IAEA trial in which India also took part, and another Dahanka 6. So there was also a TMH trial of 700 patients. Again, I'm not going to go through these trials because it's impossible to go through these in 1 hour or even in 2 weeks. But just to give you an idea of what people have done, they've compared normal fractionation with pure acceleration. Now this is normal fractionation with hyperfractionation. EORTC trials were there, RTOG 9003, which was a 4-arm trial. This is normal fractionation with hybrid acceleration. That means I've already discussed if you have combined some form of hyperfractionation with acceleration or some other form of acceleration. Again, similar continuing with hybrid acceleration versus conventional fractionation. Same, ArtScan trial was a good trial. This is the new era, the IMRT SIB era. This is only around 10, 15 years old, not more than that. So this is relatively young. And you will notice that the trials don't have, 200, 300 patients, like 70 patients, 60 patients only. But RTOG 0022 is one of the, let's say, most quoted trial for IMRT SIB when people talk of dose fractionations, at least in head neck cancers. These are some other trials. This was the largest trial of Bangkok, which was, in my opinion, a very poorly conducted trial, but okay, we won't get into that. But just to give an idea, people have done a lot of trials, a lot of studies. And what happens, this is the role of systemic therapy when added to accelerated fractionation. So accelerated fractionation plus some kind of chemo usually. Excuse me. I think my mic went off. Sorry. So this is systemic chemotherapy added to accelerated fractionation. Same thing continued here. Systemic chemotherapy added to hyperfractionation. And this is altered fractionation versus RT alone when normal fractionation with chemo. So you can, what I'm trying to do here is I'm trying to show you that so much has been published, more than I think 50 articles have been published on this, and it is very confusing. So what do we do when there is so much evidence which pulls in this direction or the other, or the effect sizes vary? What we do is we basically conduct a meta-analysis. And of course, the problem with any meta-analysis is that meta-analysis can only take care of the statistical heterogeneity. It does not take care of methodological heterogeneities or biological heterogeneities. So if you have inducted different kinds of patients, that's a biological heterogeneity. If you have given different kinds of therapies, that's a methodological heterogeneity. But still, meta-analysis will give you some idea as to where the general average metric lies. Is it in favor of something? Is it not in favor of something? So meta-analysis should not be used as a guide to change practice alone. Rather, they should be used as a guide to guide further research. And luckily, for head and neck cancers, we have a good meta-analysis called the March meta-analysis, which was first published in 2006 and then updated in 2017. And as you can see, this has the 2006 had more than 6,500 patients. It was updated to more than 12,000 patients in 2017. And this was mostly conducted on larynx, oropharyngeal, hypopharyngeal squamous cell carcinomas, which is what we usually see, and that's what we are interested in. And most of them were stage 3 and 4 tumors, which is exactly what we want to know, because for stage 1 and 2 tumors, the TCP rates are already pretty high and NTCP rates are not that problematic. So we would like to know that is there something else which we are doing compared to standard fractionation? Can we do something else which will improve the TCP and or decrease NTCP? And this is more relevant for stage 3, stage 4. So these were very relevant meta-analysis published. And what did they find? So let's start with the March 2006. I'll go a little more depth into this because this was the first one. Basically, March 2006 meta-analysis compared conventional RT with altered fractionation RT. And what they found basically was that there was around a 3.5% benefit in overall survival at 5 years, which favored the altered fractionation arm. This benefit was found to be greatest for pure hyperfractionation. That means 8% versus 2%. Similarly, there was around 6.5% benefit in local regional control. And this was greatest with hyperfractionated than with accelerated fractionation. They also found that the greatest benefit was for local control, not for nodal control or regional control, which was interesting. And this is basically the forest plot of the overall survival. This is the forest plot for local regional controls. Pretty much favors the whole altered fractionation and definitely favors the hyperfractionation group. This Kaplan-Meier curves are interesting. This is the Kaplan-Meier curve for the whole group. You can see there's a 3.4% absolute benefit. And mind you, for those who are interested in statistics, an absolute benefit is different from relative benefit. If I have to compare, I would say that the 3.5% absolute benefit is somewhat similar to what you find in breast cancer when you move on from CMF chemotherapy to CAF chemo or FAC chemotherapy. So it is that much magnitude is there. So it's reasonably good. And for a tumor site as common as head neck, it has a lot of attributability. So this means the numbers needed to treat will be lower and numbers needed to harm will be higher, which means it's a good thing. That means more and more people can benefit from it. This, by the way, is the rationale why people move from CMF to FAC, because 3.4 around 4% absolute benefit, and breast cancer is a very common disease. And so is head neck cancer, especially in India. So this is the absolute benefit of 3.4% at 5 years, favoring the altered fractionation. This is for hyperfractionation, slightly more than 8%. And this is for, you can see this for accelerated fractionation. There's almost no difference which you can make out. This was statistically significant, but barely. The most significant was found for accelerated fractionation without total dose rejection. So the point is, if you are doing acceleration and you are doing total dose reduction, you probably will not see much benefits and you probably will have increased toxicity. Now, there was a 2017 update, as I said. What did they find? They had two comparisons. One was continuation of the conventional RT versus altered fractionation RT. Now they had more number of trials, more number of patients. The same 3% benefit in overall survival persisted, as did the around 6.5%, 6% benefit in local region control. The interesting thing was, in the second comparison was, they compared altered fractionation RT of all kinds with normal fractionated RT with concurrent chemo. So AFRT versus conventionally fractionated CCRT. And what was interesting was that AFRT fared worse in this, around 6% worse, absolute difference again. So this is very important. When people talk of accelerated altered fractionation of any kind, one has to keep into mind that altered fractionation is one part of the picture. What about the concurrent chemo part? And we already have, this is not my part of my lecture now because it's not part of the topic, but we already know from McKenzie meta-analysis that concurrent chemoradiotherapy is the most efficient and most beneficial form of chemotherapy to be delivered with radiation as compared to, let's say, neoadjuvant or adjuvant. Again, I'm talking of HNSCC, not nasopharyngeal carcinomas. So this particular fact should be kept to the mind. This is the overall survival hazard ratio, and you can see that this is pretty much not significant. The 95% confidence interval is sorry, it is significant, but it's the 95% confidence is up to 5% relative benefit. Overall, 0.2 to almost 22% relative benefit. So thus far, we have basically covered about, thus far we have basically covered about altered fractionation versus either conventional fractionation or altered fractionation with conventional fractionation with chemotherapy. But what about altered fractionation with chemotherapy versus altered fractionation by itself? So very few trials exist, unfortunately. And because when very few well-conducted large RCTs exist, what you can do is something called as a network meta-analysis. So just a brief overview. A meta-analysis is basically when you combine multiple trials comparing A with B, A with B, A with B. But if you have A with B and you have B with C, A versus B and treatment B versus treatment C, but you want to see what is the difference between treatment A and treatment C, but no trials exist of this kind, or if they exist, they're not very great. So you can do something called as a network meta-analysis, which will indirectly allow you to compare A with C. So it will compare A with B and B with C, and then you will indirectly compare A with C. Now, mind you, this has a lot of caveats and loopholes and statistical nuances to understand. So NMA's network meta-analysis should never be used to change practice. They should at best be used to guide new research maximum, or maybe just understand something. Okay, this thing might exist. Please don't use NMAs to guide change your general practice. However, this meta-analysis was published, NMA was published in 2018, and there's an interesting NMA. What they did basically was that they compared conventional fractionation with conventional CCRT, with HFRT, pure HFRT, with HFRT with CCRT, accelerated fractionation, acceleration fractionation with chemotherapy, acceleration fractionation hyperfractionation, that means hybrid HFART, with chemo and without chemo. So basically, whatever combinations you can think of, basically they try to cover this. And so you can imagine this is going to be a very complex meta-analysis. Again, I am not going to cover this because this will take at least 1.5 hours to discuss. But the upshot basically was that they found that for all things, adding chemotherapy benefited the versus pure acceleration. Any form of acceleration was better than RT alone, conventional RT alone. Any form of actually altered fractionation was better than conventional RT alone. Adding chemotherapy bettered the survival, the local regional control more. However, it resulted in a lot of toxicity. Again, as I said, please do not use this to change your practice. You can maybe at best conduct some research based on this. Now, this is so far we are talking about de novo cases. What about post-op? Do you think post-op has something? I mean, post-op patients come to us after 6 to 8 weeks. Sometimes it takes around 3 months to start. Can acceleration or some other form of altered fractionation take care of that supposed repopulation of cells? Maybe, maybe not. There have been trials that have been conducted, and because they had results all over the place, so hence a meta-analysis was conducted. So what was this meta-analysis? This was conventionally fractionated RT versus accelerated fractionation RT in post-op head and neck cancers, high risk meaning either N3 with N2 with ENAs, T3, T4 disease, etc. So the upshot was that they found that accelerated radiotherapy did not improve local control or overall survival. However, the acute mucositis was higher. So basically, if you have conventionally fractionated RT alone versus accelerated RT alone, you probably will not be able to have much benefit with accelerated RT over and above the conventional fractionated RT. Now, most of the times now, after EORTC and RTOG and Burney and Cooper trials and McKenzie meta-analysis, as it is, we don't do this. We usually treat high-risk post-op cases with conventional RT with concurrent chemo. So will accelerated fractionation be better than conventional RT with concurrent chemo? Very unlikely, because it was not better than conventional RT alone. So it's unlikely to be better than conventional RT with concurrent chemo. Can accelerated fractionation RT with chemo be better than CCRT with conventional fractionation? Maybe, we don't know. There's no real trial which I've read of at least. So maybe somebody can conduct a good 500 patient trial and we will get that later on. But as things stand today, pretty much, in my opinion, the chapter is closed on accelerated fractionation RT alone for high risk tumors post-op. So what is a summary? I've confused you thoroughly. I know that. Once you go back and read this and read the textbooks, hopefully you'll be able to gain things better. But the summary is this. Take home message is, altered fractionation RT in any form may be significantly superior to conventional fractionation, but maximum benefit is limited to hyperfractionation only, which means hyperfractionation means BID dosing. Accelerated fractionated RT has a higher toxicity than conventional fractionated or hyperfractionated RT. Altered fractionation alone is inferior to conventionally fractionated concurrent chemoradiation. Altered fractionation with concurrent chemo, is it better than CFCCRT? We don't know that. Adding concurrent chemo to any form of acceleration results in much higher toxicity rates and has not yet been proven to increase either local regional control or overall survival rates. However, HFRT with concurrent chemo may be better in terms of LRC, but in the trials which have been conducted, phase 2 trials or single arm studies, they had higher acute toxicity and even higher late consequential toxicities. The best form of altered fractionation is unfortunately dependent on your scenario, your system, your resources, on your logistics. If you can deliver 6 fractions in a week, fine, go ahead, do it. Why not? There's evidence for that. But most people cannot deliver 6 fractions in a week. If you can deliver two BID dosing, go ahead, do it. Most people cannot deliver BID dosing in your routine clinical practice. Maybe for a thesis or a protocol, you might be able to do for 15, 20 patients. But imagine if you're treating 60 patients in iliac of head neck, 70, 80 patients total, all 50 of them are head neck. Now you have to do 50 of them and deliver BID treatment. It's not even possible to do that with at least 6 hours apart. It's just not possible. So most of the times, unfortunately, altered fractionation has not yet reached not as utilized its ultimate potential because of logistic and resource related constraints, not because of radiobiology. And that's my topic. Thank you. And this is my resources. Please go and check up on them if you want. And with this, I am willing to take your questions, if any.
Thank you, Dr. Shantanu. We have a few questions. So I'll first start with the questions posted.
Yes, sir.
First question is, any
Dr.
difference
Ashutosh, you have to speak loudly.
Okay, ma'am. So, one minute. I think yeah. Now is it okay?
I can hear you.
Yeah. Any difference in choosing altered fractionation according to histological type or tumor grade?
Okay. So, yes, sir.
Yeah.
So whoever asked that question, it's a good question. But I would like to point out.
Dr. Shantanu.
Sorry? Yeah, this is from Dr. Surbi.
Okay, it's a good question, but I would like to point out that most of the trials, even the meta-analysis, were done basically on squamous cell carcinomas of head neck, not on adeno or any other thing. So we cannot really talk about that. We don't have evidence. May or may not be. We don't know. We don't have the evidence. This is regarding the histological type. As regarding the grade, again, this was looked into a meta-analysis, but there was no significant. The literature was far too heterogeneous to come up with any standardized claim regarding this. So as things stand today, histological grade is not considered one of those parameters in which you will solely move on from conventional fractionation to any form of altered fractionation. I hope that answers the question.
Yeah,
okay.
Thank you.
So there is one more question from Sunita Prabhakar. Is there a comparison between Sataximab and Rt with altered fractionation for patients not fit for chemo?
Yeah, just once again, I think, if I'm not wrong, there was a couple of trials. I was hoping not to get into that because individual trials are a problem. It's difficult. Each of them is a journal club unto itself. But let's see. Yeah, so ArtScan trial, I think, was one of the trials which has compared, no, not ArtScan, sorry. Cetuximab, she's asking. Oh, yeah. I don't know. No, I don't know. I'll be honest, I don't know.
So we have had trials of conventional fractionation with cetuximab and RT alone, that was the Bonner, and then
Yeah,
follow on with cetuximab plus cisplatin versus cisplatin. So in that,
which was a failure.
cetuximab was inferior.
Yeah,
So we have that data, but I
but
don't think we have
oxalated, I
any
don't know.
data on altered fractionation with
Not to
or
the best of my
without
knowledge.
cetuximab.
Not to the best of my knowledge.
Yeah, so I think now there are a few ongoing trials using nimotuzumab and other biomolecules, but it's still in the future.
Hmm.
Okay, Shantanu, I have a question.
Dr. Ashutosh, you are not properly audible.
Okay,
Yes,
okay.
sir. Now you are
Ma'am,
audible.
am I now?
Yeah.
Now you are.
So I apologize. So I have a question, Dr. Shantanu, is uh, regarding the one more part of your talk. Would you like to talk about, and just in brief, or maybe 5 minutes, or just 2-3 minutes, about the role of dose escalation, whether in
Okay.
oropharynx, nasopharynx, oral cavity, larynx, and hypopharynx? So, if you can
All right.
broadly divide into these areas, just a
Fine, sir.
line or two each.
Yes, sir. So dose escalation, at least with radiation, at least because dose escalation can be done with other things, but I'm talking of radiation dose escalation only.
So,
So
radiation dose escalation.
yes, sir. Dose escalation has been tried in nasopharynx especially, and with some good results. I mean, they have gone up to I think 74 or 76 gray with some good results.
Hmm.
But my issue with oropharynx, hypopharynx, and oropharynx and larynx is that whenever dose escalation has been tried in the accelerator RT arms, some of the accelerator RT, the grade 3 plus toxicity is more than 50%. I think in one of the trials it went up to 56 or something percent, 55% or something. So I'm not against it, but currently I see it mostly as in the research phase. It's pretty much investigation. It's definitely not as clinical routine clinical practice. But yes, people are trying it for it. In nasopharynx, especially, I did not bring that up because I was talking mostly about altered fractionation and HNSCC. But you have rightly pointed out, sir, that in nasopharynx, people have tried for dose escalation using brachytherapy. And nowadays they're trying to do it with SBRT also. And with brachytherapy, they did find a lot of increased local control rates. Although interestingly, if I remember correctly, the overall survival is not very much different. And they did find increase in late toxicities like synechiae formation and things like that, cartilage issues. But when done properly, and this is key with brachytherapy, when done properly, because brachytherapy is basically a skill. When done properly, it might be a very viable solution, at least for nasopharyngeal. Not sure about oropharyngeal because I'm not really read of any randomized trials being done in oropharyngeal. A lot of single arm studies are there, including one from TMH and other places, even AIMS, but they're all single arm studies. No, I have not read of any randomized trial which has compared conventional fractionation RT versus conventional fractionation RT plus brachy boost in either oropharynx or hypopharynx or well larynx में तो हो ही नहीं सकता.
So I think there'll be some studies. I mean, they won't be big RCTs, but small, maybe part of thesis coming from Dr. DN and from Dr. Bhalawat at Jupiter. So, and from TMH. So yes, you will have some studies in oropharynx about brachy boost versus IMRT boost, sequential mainly. But then those are mainly academic interest, but they are not practice changing as such.
Yeah, I would like to say that given that this audience is basically MD students, I would not like to encourage them to think of that as standard. I would like to say that that's research. Let us keep it that is academic research. This is definitely not the standard of care currently or in routine clinical practice. However, that being said, most of boosts are actually being tried using IMRT SIP nowadays, at least in oropharynx and hypopharynx, at least, which might be, we'll see how that turns out, because there are a couple of randomized trials which are ongoing. I think one in the US, I think, and Andy Anderson or Sloan Kettering, one of these institutes is doing, in which they are going up to 2.5 gray per fraction, if I'm not wrong. So that'll be interesting to find out how what turns out. Is the late toxicity, acute toxicity is definitely going to be higher, but is the late toxicity high enough? I would actually be interested in knowing that whether these trials are being performed as non-inferiority trials for both TCP and NTCP, because I don't think TCP will increase to very much. It should be at least non-inferior to that.
No, but I
Hyper,
would be skeptical. Sorry,
I would be
sorry, Dr.
skeptical.
Raj.
I agree. I agree with you. I would be skeptical. I am more sanguine about the trials which are comparing hyperfractionation with concurrent chemo versus hyperfractionation alone or conventional fractionated CCRT. Those trials sound interesting to me, but logistically, I don't think we can ever do them in India.
See, for India, my main ground for skepticism would be actually the tumor bulk and the tumor volume. For dose escalation, the volume needs to be restricted. Otherwise, we are going to have very bad late toxicities, and patients are going to end up with aspiration or necrosis. So the one place where it's really worked out was in that phenomenal paper by Levendag in nasopharynx. But in
Yes,
other places, it's really not worked out.
I agree with you. Another problem would be, I would see case selection as a problem because most patients here would come with N2, N3 nodes. And with
Yeah.
that, you really can't deliver, 74 gray because carotid blowouts rates are definitely higher. Stroke rates are definitely higher with the dose per fraction. As the dose per fraction increases, there's reasonable evidence now to not level 1 evidence, but reasonable level 2 evidence to understand that if we are going to increase total doses more than 72, 74 gray to the carotids and or increase dose per fraction to more than 2.2 gray per fraction, we will probably end up with more either carotid blowouts and or strokes, which unto themselves are problems.
Yeah.
So any other
Shantanu,
questions, sir?
Shantanu, can I
So I
Yes, sir.
don't think we have other questions. Yes, Dr.
So
Sapru.
Shalin sir is saying something, sir, please.
Yeah.
So Shantanu, if you go back to the first major classic trial on altered fractionation 9003, you had 70 gray 35 fractions in the conventional arm, and the hyperfractionated arm was probably 1.17 BID into uh, into 68 or 70 fractions, which took the total dose to 81 gray. Can you show that?
Yes, sir. This is
That arm.
here.
So
This is the one.
assuming that, where is this now? Yeah, 1735. And what is the hyperfractionation arm?
So hyperfractionation is 67.2 gray in 42 fractions. At sorry, 1.5. Yeah, 1.5.
No, no,
No,
no,
no,
no,
67.2 gray into 42 fractions. I'll have to calculate what the dose per fraction was.
no, 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 no. There is one arm that is missing.
So
Studies
one is
compare normal with hybrid acceleration. It is, yes, hybrid acceleration. There is no acceleration. It is a 7-week trial. There were 4 arms. There
yes, sir.
is there's a concomitant boost arm, as you show. There's an accelerated fractionation with split. That was the worst.
Yes, sir.
And standard was this, and the hyperfractionation was 1.17 BID for a total dose of 81 gray.
So yes, yes, sir. I remember it being 1.2, but you might be right, sir.
Yeah, 1.2 into 35 into 70 fractions takes it to 84. That is not
Sir.
doable. It is
Sir.
81 point something. So
Sir.
when Ashutosh asked this question, when you look at dose escalation, when you hyperfractionate for the same number, for the same overall treatment time, but you increase the number of fractions and therefore decrease the fraction size, maintaining interfraction interval, there is an implicit dose escalation. And
Yes, sir.
that is the first example of dose escalation that works in the garden variety of head and neck cancers. Is that not right, or have I got it completely wrong?
So no, I would both agree and go one step beyond if it's all right, sir. I would say that yes, that is definitely dose escalation because the total dose is increasing. But I would also like to point out that the total dose needs to increase. Otherwise, we will have decreased TCP because we are fractionating into 1.2 gray, for example, BID. So the cell survival curves, the TCP curves will become shallower. So we need to increase. So hyperfractionation, I personally do not consider hyperfractionation to be a dose escalation because that kind of dose escalation is basically for equating TCP, not increasing TCP.
So probably what he's saying is that's the equitable dose, that's the equivocal dose. Now, do we need to go beyond that for dose escalation? Pure dose escalation means the equivalent. Do we need to? Is there a benefit of moving beyond that equivalent dose?
Ashutosh, pardon me, just a minute. Let's get this right. When you hyperfractionate 1.17 BID to 84 gray. It is iso-effective for late effects, and it increases the tumor control. If you keep the same total dose with hyperfractionation, same total dose, then you will be iso-effective more or less for tumor control, and you will have less late morbidity.
Yes, sir, exactly.
Yes, so please understand there is dose escalation.
Sir, my issue is, sir, with this is, when we say dose escalation, do we mean TCP, NTCP, or what?
No, we
So,
mean TCP. And
yes,
so TCP
so then
goes
it's
up.
fine.
TCP
Yes.
goes up. The TCP goes up without keeping the same late effects. That is the fundamental premise of hyperfractionation. If you keep
Agreed,
the
sir.
same
Yes,
total dose, your late effects become lower. So while
Yes,
I accept that, we are discussing SIB as a way of dose escalation and better conformality and, other kinds of things and, separating the TCP and NTCP curves, but hyperfractionation in its purest form and its first form is dose escalation, keeping same late effects.
agreed, sir. Yes, sir.
Okay.
So the distinction I would draw is that hyperfractionation acts more on the NTCP curve. It tries to draw the NTCP curve more to the right, while the SIB or acceleration tries to drag the TCP curve more to the left.
The SIB, so simultaneous integrated boost, means you give 2 gray in the morning and possibly 1.2 gray by evening, interfraction interval 6 hours. Is that right?
So no, sir. No, sir.
Okay.
SIB is
SIB
2.2
means,
gray.
right, no, wrong. SIB means, okay, that's concomitant boost. That's a variant on concomitant boost. SIB means you could give 1.8 gray per fraction to large volume and 2.2 gray fraction to a small volume, the GT.
Yes, sir.
I've
Yes,
got
sir.
it. Or 2 and 2.2. Yes, of course.
Sir,
That
2
is
would
also
not be, sir, 2 would not be considered as a boost, sir, because it's technically not a boost.
I accept. 2 and 2.2. 2.2
Yes, sir.
is the boost. Yes.
Yes, sir.
The SIB portion, so if you give 2 and 2.2, so let's say subclinical disease, 50 gray in 25 fractions, and 2.2 gray means it gets 56 gray in 25 fractions, which, because you have sort of, that would be roughly equal to 60 gray in 30 fractions in terms of tumor control. Although in 5 weeks, delivered in 5 weeks. So the advantage is double. You've increased the fraction size and you've cut the overall treatment time by 1 week, which, if you look at the kickoff times, saving 60 centigrade per day saves roughly 7 gray. So that's where the advantage comes when you give the SIB, if you complete it well within time. There's also the advantage of having a lesser overall treatment time. Think about it.
Sir, only a few fractions, sir. Most of the times we give 70 gray in 33 fractions. So that's 2 fractions off. It's 35 to 2 or 3, not by much. But what I would like the students to understand is that acceleration basically works on dragging the TCP curve to the left, while hyperfractionation works on dragging it to the NTCP curve to the right. And hybrids work in between, somewhere in between.
Perfect. Perfect.
I mean, I think they should understand this concept at least.
Perfect.
So, thank you, Dr. Shantanu. I'll hand over to Dr. Surbi now.
Thank you so much, Dr. Shantanu Sapru, for such a nice deliberation. And
thank you, ma'am.
Thank you, Dr. Ashutosh, for such an interactive session for moderation. Thank you, Salin sir, for your concluding remarks. And thank you, RPG, for giving this platform to us. Thank you, all the participants, and happy Holi to all of you. Thank you so much. Good night.
Thank you, ma'am. Thank you, Shalin sir. Thank you, ma'am. Thank you, Shashwat sir. Bye.
Good night.
Good night. Bye.